Welcome to our video on gout. Let's begin. For gout, we will discuss its definition, pathophysiology, clinical presentation, diagnosis, differential diagnosis, and management. Gout is an inflammatory crystal-induced arthritis due to deposition of uric acid crystals in joints and soft tissues. Gout is more common in men. Let's talk about the pathophysiology. Increased plasma uric acid levels predispose to gout. Uric acid is the breakdown product of purine metabolism. Interestingly, it is not obligatory to have hyperuricemia to develop gout. In other words, people without hyperuricemia can develop gout, and people with hyperuricemia might never get the gout. There are primary and secondary types of hyperuricemia. Primary hyperuricemia is an idiopathic increase in plasma uric acid levels without any comorbidities or medications affecting uric acid production or excretion. Secondary hyperuricemia, on the other hand, is due to decreased excretion or increased production of uric acid. Decreased excretion of uric acid is the most common cause of secondary hyperuricemia and gout. Before we discuss the different causes of urate underexcretion, let's emphasize one way to remember these causes. Any medication or condition that increases organic acids predisposes a patient to uric acid accumulation. The reason is that almost all organic acids, including uric acid, are secreted by the same transporter in the nephron. Therefore, if other organic acids accumulate, they compete with uric excretion, and uric acid is retained in plasma. Any medication that is a weak organic acid can induce hyperuricemia. These medications include aspirin, loop and thiazide diuretics, pyrazinamide, and niacin. Ketoacidosis causes accumulation of ketoacids, namely beta-hydroxybutyrate and acetoacetate, which compete with urate secretion. Alcohol is metabolized to acetate, the weak organic acid. Therefore, acetate will compete with urate for secretion in the setting of excessive alcohol consumption. Chronic kidney disease decreases uric acid secretion, predisposing to gout. Postmenopausal age is another risk factor for gout. Normally, estrogen stimulates uric acid excretion. Low levels of estrogen in postmenopausal women predispose to uric acid retention in gout. Von Gurke disease is a type 1 glycogen storage disease characterized by hypoglycemia and lactic acidosis. Accumulated lactic acid competes with uric acid for secretion. Therefore, these patients may have hyperuricemia and gout. Here is the illustration of the proximal convoluted tubule showing uric acid secretion. As we already explained in the previous slide, secretion of all organic acids, including that of uric acid, occurs by the same renal transporter. So if other organic acids accumulate, then they will compete with urate for secretion, and uric acid will accumulate in the blood. The less common cause of secondary hyperuricemia and gout is increased production of uric acid. As we already mentioned, uric acid is the breakdown product of purine metabolism. Purines make up the DNA. Therefore, any condition characterized by rapid cell turnover or cellular destruction can cause hyperuricemia. These conditions include tumor lysis syndrome after initiation of chemoradiotherapy. Hematologic malignancies such as leukemia and lymphoma have high cell turnover rate and predispose to hyperuricemia. Additionally, increased uric acid production might be due to enzyme defects. For example, Lesch-Nyhan syndrome is an X-linked recessive condition characterized by inability to salvage the purines. Therefore, excessive purines end up being converted into uric acid. Additionally, the diet rich in purines like seafood and red meat can cause hyperuricemia. Lastly, obesity and hypertension, as well as hypercholesterolemia and hypertriglyceridemia, are associated with high serum uric acid levels. A 56-year-old man comes to the emergency department due to pain in his left foot. He started chemotherapy 2 weeks ago for recently diagnosed chronic myelogenous leukemia. The physical exam reveals erythematous, swollen, and painful left first metatarsophalangeal joint. What is the most likely pathophysiology of the physical exam findings in this patient. This patient presents with erythematous, swollen, and painful left first metatarsophalangeal joint. This is the classic description of an acute gout attack with podagra. Considering that he has recently started chemotherapy for chronic myelogenous leukemia, the rapid leukemic cell destruction likely caused excessive purine breakdown and hyperuricemia. Hyperuricemia, in turn, induced the acute gout attack in this patient. Gout can be classified into acute and chronic types. An acute gout typically presents with monoarthritis, most commonly in the first metatarsophalangeal joint or the big toe. Involvement of this joint is also called podagra. Acute gout is characterized by severe localized pain, warmth, erythema, and swelling of the joint. Attacks are common at night, waking the patient up. The patient might also have fever. Other joints less frequently affected in gout include ankle, knee, elbow, and metacarpophalangeal joints. Here's an image showing what podagra looks like. Please take a look at where the black arrow points and notice this erythematous and swollen first metatarsophalangeal joint. Let's move on to chronic gout. Chronic gout is characterized by progressive joint destruction due to intra-articular deposition of monosodium urate crystals. Additionally, one can see tophi in chronic gout. Tophi are painless white hard nodules within the bones like elbows or soft tissues such as pinna of the ear or tendons. Finally, chronic uric acid nephropathy can occur. It is a type of chronic tubulointerstitial disease due to monosodium urate crystal deposition within the kidneys. Here you can see an image showing the tophus. Please take a notice at these hard white nodules. Let's move on to the diagnosis of gout. Arthrocentesis with synovial fluid analysis is the gold standard for diagnosis. Polarized light microscopy is commonly used to visualize monosodium urate crystals. These are negatively birefringent needle-shaped crystals. In other words, if the crystal is parallel to the polarized light, it appears yellow. If it is perpendicular to the light, it appears blue. Additionally, synovial fluid white blood cell count is usually from 2,000 to 50,000 cells, suggesting non-infectious inflammation. Finally, synovial fluid gram stain is negative, favoring the diagnosis of gout over septic arthritis. Here is a polarized light microscopy image showing monosodium urate crystals. Let's recall that when crystals are parallel to the light, they appear yellow. In contrast, when they are perpendicular to the light, they appear blue. Imaging studies can also be used to diagnose gout. Ultrasound of the affected joint usually shows bony erosions and the double contour sign. Double contour sign is the presence of the hypoechoic articular cartilage between hyperechoic crystals and bone layers. As for the X-ray, it's usually normal in acute gout. In contrast, X-ray in chronic gout usually shows punched out lytic bone lesions. CT and MRI are rarely performed in patients suspected of having gout. This is the graphical representation of the double contour sign in the joint affected by gout. Please note the hypoechoic articular cartilage and the hyperechoic cortical bone on the bottom of control and the joint with gout. However, joint affected by gout has the hyperechoic crystal layer on top. That is absent in the normal joint. Hyperechoic layers of bone on the bottom and crystal deposition on the top create double contour sign. Here you can see an image of the joint affected by gout. Hopefully you can appreciate these punched out lytic bone lesions, also known as rat bite erosions. Finally, gout can be diagnosed clinically if the physician has low suspicion for septic arthritis and the patient has the typical clinical presentation with monoarthritis. The patient should meet all these criteria in order for the gout to be diagnosed clinically. It's worth mentioning that measurement of serum uric acid level is not recommended during the acute gouty attack because it does not predict the overall prognosis of the patient. A 68-year-old man comes to the physician due to right foot pain that awakened him at night. His past medical history includes stable angina, hypertension, and chronic kidney disease stage 2. He takes low-dose aspirin and hydrochlorothiazide. The physical exam reveals painful, swollen, and erythematous right first metatarsophalangeal joint. Arthrocentesis is performed. What will most likely be seen under polarized light microscopy? This patient presents with painful, swollen, and erythematous right first metatarsophalangeal joint. Considering that he takes low-dose aspirin and hydrochlorothiazide, and he has chronic kidney disease, he likely has hyperuricemia complicated by acute gout attack. Arthrocentesis is performed. Polarized light microscopy typically shows negatively birefringent needle-shaped monosodium urate crystals in the patient with gout. Let's move on to the differential diagnosis of gout. Septic arthritis is on the top of the differential diagnosis. In contrast to gout, septic arthritis presents with more systemic signs such as fevers, chills, and possible sepsis. Additionally, complete blood count would show severe leukocytosis with a possible left shift. Another diagnosis to consider is the calcium pyrophosphate deposition disease, that is pseudogout. However, attack of pseudogout usually lasts longer than that of gout. We will discuss pseudogout in great detail later in this lecture. Rheumatoid arthritis and erosive osteoarthritis can also present with joint pain, swelling, and erythema. However, both of these conditions usually present with more than one joint involved. Finally, seronegative spondyloarthritis, like reactive arthritis, or psoriatic arthritis, should be considered in the differential diagnosis. In contrast to gout, these conditions have distinct associated features. For example, reactive arthritis can be associated with urethritis and conjunctivitis, while psoriatic arthritis is associated with psoriatic skin lesions. We will now discuss the management of gout. Let's start with the general recommendations. First, patients with gout should limit alcohol, seafood, red meat, sugary foods, and juices. The reason is that all these foods and beverages can result in high uric acid levels and an acute gout flare. If the patient is obese, he or she should be encouraged to lose weight. One should also avoid the medications discussed in the previous slides because those medications are associated with gout exacerbation. Finally, if the patient has a concomitant hypertension, the preferred medication is losartan because losartan has shown to mildly decrease the serum uric acid levels. Acute gout is treated with either nonsteroidal anti-inflammatory drugs, colchicine, or corticosteroids. NSAIDs, especially naproxen or indomethacin, are preferred as the first-line agents unless the patient has chronic kidney disease or peptic ulcer disease. NSAIDs will exacerbate both of these conditions. Additionally, we should avoid low-dose aspirin in acute gout because aspirin in low doses decreases renal excretion of urate and increases serum uric acid levels. Colchicine is an alternative to NSAIDs. However, it is contraindicated in liver failure and chronic kidney disease because of its hepatic metabolism and renal excretion. Corticosteroids such as prednisone or prednisolone can be administered orally, intravenously, or via intra-articular route. Corticosteroids are used when the patient has a contraindication or resistance to NSAIDs or colchicine. For example, we will avoid both NSAIDs and colchicine in chronic kidney disease due to their nephrotoxicity, and we will administer corticosteroids. It's worth noting that the systemic formulations of corticosteroids are avoided in patients with diabetes mellitus because steroids can further increase the blood glucose levels. Let's now talk about the treatment of chronic gout. Firstly, since chronic gout medications are associated with precipitation of acute attack, pre-treatment with NSAID, steroids, or colchicine should be started beforehand. The first-line agents for chronic gout are xanthine oxidase inhibitors such as allopurinol and febuxostat. Xanthine oxidase is an enzyme that produces uric acid. Therefore, blockage of xanthine oxidase will reduce the overall serum uric acid levels. Allopurinol is a sulfa drug. It is discontinued in case of even mild cutaneous reaction because allopurinol can ultimately induce Stevens-Johnson syndrome or toxic epidermal necrolysis. Febuxostat, on the other hand, is avoided in patients with cardiovascular disease such as previous myocardial infarction or angina. This is because febuxostat can exacerbate cardiovascular disease. Interestingly, both of these drugs increase the serum azathioprine levels. Let's explain this phenomenon with the help of an illustration. Azathioprine is an antimetabolite chemotherapeutic drug broken down by xanthine oxidase. Blockage of xanthine oxidase, either by allopurinol or febuxostat, will increase the serum levels of azathioprine and cause severe myelosuppression. A 72-year-old man comes to the physician for a follow-up visit after an acute gout attack. This was his third attack in the past year. He has chronic kidney disease stage 3. His past medical history is significant for an anaphylactic reaction to trimethoprim sulfamoxazole. The physician decides to prescribe a xanthine oxidase inhibitor to the patient. Which medication is preferred in this patient? This patient has had 3 acute gout attacks in the past year, and the physician decides to prescribe a xanthine oxidase inhibitor to him. He has a history of an anaphylactic reaction to trimethoprim sulfamoxazole. In other words, he has a severe sulfa allergy. There are 2 drugs inhibiting xanthine oxidase, allopurinol and febuxostat. Allopurinol, however, is a sulfa drug. Therefore, it should be avoided in this patient with sulfa allergy. The preferred medication for him will be febuxostat. Let's talk about uricosuric agents like probenecid in the management of chronic gout. They are the second-line agents for chronic gout. Probenecid blocks the reabsorption of unfiltered uric acid from the proximal convoluted tubule and increases urinary uric acid levels. It is avoided in urate nephropathy because increasing the urinary uric acid concentration can further precipitate uric acid stone formation. Probenecid also inhibits renal penicillin secretion because penicillin is secreted by the transporter responsible for urate reabsorption. Therefore, probenecid can increase the serum penicillin levels. Here is an illustration showing the mechanism of action of probenecid. As we already explained in the previous slide, probenecid blocks the renal transporter responsible for uric acid reabsorption. Interestingly, this transporter secretes penicillin as well. So penicillin will accumulate in blood in case of concomitant probenecid administration. The third-line agent is pegloticase, that is recombinant uricase. Pegloticase converts uric acid to allantoin, the water-soluble metabolite easily excreted by kidneys. It is avoided in patients with glucose-6-phosphate dehydrogenase deficiency. Uric acid conversion to allantoin produces hydrogen peroxide as a byproduct. Patients with G6PD deficiency are particularly susceptible to free radicals, and pegloticase can precipitate acute hemolysis in these patients. This drug is also avoided in congestive heart failure because pegloticase exacerbates this condition. It is associated with anaphylaxis. Pegloticase is not given together with xanthine oxidase inhibitors or probenecid. Both xanthine oxidase inhibitors and probenecid decrease the serum uric acid levels. Pegloticase, on the other hand, converts the serum uric acid to allantoin, so the efficacy of pegloticase decreases with the concomitant administration of the first 2 drugs. Finally, it's worth noting that no change should be made to the chronic gout therapy during the acute gout attack. In other words, if the patient has never taken chronic therapy, we should not start it during the acute attack. On the other hand, if the patient is already on chronic therapy, we should not change its dose during acute gout. Let's illustrate how pegloticase works. So here we have uric acid, which is converted to allantoin by pegloticase. This reaction produces hydrogen peroxide as a byproduct that can cause hemolysis in G6PD deficiency. Finally, since xanthine oxidase inhibitors and probenecid decrease the serum uric acid levels, they also decrease the efficacy of pegloticase. Here we have the table summarizing similarities and key differences between gout and calcium pyrophosphate deposition disease. Please pause the video and take a moment to consider this table. A 71-year-old man comes to the emergency department due to right foot pain. He has past medical history of type 2 diabetes mellitus for 20 years and chronic kidney disease stage 4 for 5 years. His last hemoglobin A1C was 9% 3 months ago. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 145/90, heart rate of 91, and respiratory rate of 17. The physical exam reveals erythematous, swollen, and painful right first metatarsophalangeal joint. There are chalky subcutaneous nodules on the elbows and the pinna of the left ear. Which of the following is the best treatment option for this patient? A. Naproxen, B. Colchicine, C. IV corticosteroids, or D. Intra-articular corticosteroids. This patient presents with erythematous, swollen, and painful right metatarsophalangeal joint. This is a classic description of an acute gout attack. Now the question asks about the best treatment option for this patient. All of these drugs, naproxen, colchicine, and IV and intra-articular corticosteroids, can potentially be used for acute gout attack. However, we should consider each patient's comorbidities and preferences. The best treatment option specifically for this particular patient will be option D, intra-articular corticosteroids. The reason is that intra-articular corticosteroids have mostly local effect, so they will not exacerbate his diabetes mellitus or chronic kidney disease. Here's the slide reminding us of when we should use corticosteroids in the management of acute gout. Let's discuss why other options are incorrect. Option A, naproxen, and option B, colchicine, are incorrect because they are avoided in patients with chronic kidney disease. Finally, option C, intravenous corticosteroids, should be avoided in this patient because systemic corticosteroids would exacerbate his uncontrolled diabetes mellitus. And that concludes our lecture on crystal-induced arthritides.